The first half today will be devoted to coronavirus, but the second half, I'm going to be talking about monkeypox. So if people are interested in that new potentially emerging threat, please stay here for the second half of the presentation.
Absolutely. So
thank you. Good morning, everyone. I'll just proceed to the numbers here, but first, just a commentary. We're holding steady right now. And what we're seeing is a decoupling between case numbers, which we believe are a gross underestimate of the actual burden of COVID-19 infections in the community, and serious outcomes like hospitalization and death. And this is trending in the favorable direction. So unlike even through the Delta and Omicron waves that we experienced at the end of last year and in January of this year, when there was a clear connection between cases and bad outcomes, we seem to be doing quite a bit better. I will, though, say we can't rest on our laurels. It's good to celebrate that things seem to be going well now, but I'll talk a little bit about potential emerging threats in the COVID area at the end of the slides here. So the daily case count is holding steady. It's been really between 1,500 and 2,000 for over a month, and it's trending flat. Our positivity rate is higher than optimal, but again, we know there are a lot of people that are doing home testing that are either quarantining or isolating on their own and not reporting their cases. And the only way the cases get reported to the Department of Health Services is through a positive PCR test administered by a certified laboratory. So if you're taking a rapid test at home, that does not get reported. The reproductive number actually has come down slightly below 1, although this may be an outlier. We have consistently had numbers hovering a little bit above 1 for the last 6 weeks. So we'll see how that plays out over the next week or so. In Milwaukee, similar trends, 7-day average is flat at about 300 cases. Really been there now for almost 2 months. And the positivity rate, again, is higher than we'd like to see it. We want it to be below 5%, but that's not a surprise because we know that there's a pretty significant burden of cases that are not being reported. So it's not a surprise that the ones that are reported also have a high positivity rate. Go to the next slide, please. Thank you, Chris. Deaths are in the low single digits, which is good. Again, highlighting some of the points I was making earlier about there being a decoupling between high case burdens and bad outcomes, at least with the BA2 and the BA2.12.1 variants that are predominating right now. Hospitalizations have been holding steady between about 350 and 400, and they are flat. ICU census is creeping up just a little bit, but is very manageable at 61 in the entire state of Wisconsin. The ICU occupancy and hospital bed occupancy rates are closer to optimal than they have been in a long time. Recall that we want our ICUs to be running at about 80% occupancy. That's when they're most efficient. And hospital beds somewhere between 80 and 85%. So we're close to an optimal range. So there's plenty of capacity left. And the ICU burden here in southeastern Wisconsin is pretty low at only 38 patients. Next slide, please. I want to give vaccine updates here. There's a lot of activity ongoing. We expect approval perhaps later this week or authorization of Pfizer and Moderna vaccines for kids 6 months and older. And you can see there that the Pfizer is a 3-dose regimen, and that's at 1/10 the strength of the adult dosage. And the Moderna is a 2-dose regimen at 1/4 of the adult dosage. Actually, today, the FDA advisory panel is meeting, and they're expected to meet tomorrow. I believe those public hearings are being televised, perhaps on C-SPAN. So if you want to tune in, that would be great. Also, some activity for boosters or for customizing the vaccines going forward. As you'll recall, the vaccines that we're currently administering were all designed against the virus that was circulating in January of 2020. And as you know also that the COVID-19 virus has mutated many times in the interim. and that we're really fortunate that the vaccines continue to provide strong protection against bad outcomes, but we can't expect that to hold forever. So Moderna is testing a bivalent or two-component vaccine that seems to be giving promising results with antibody responses that appear to be 5 to 8 times stronger than the older vaccine dose. And so what is in the bivalent vaccine is the current vaccine composition, again, with the antigen being designed against the virus that was circulating in January 2020, but also an antigen targeted against some of the Omicron variants that are circulating right now. So this should give us better and perhaps more long-lasting protection than what are now becoming relatively old vaccines. So we expect that there should be some action, and the committee is going to be meeting on June 28th to discuss what the most rational modifications of the COVID-19 vaccines would be for the fall of 2022, either for the primary series or for boosters. So stay tuned for more advice there. And also some promising news. Novavax is going to be a late entrant into the US COVID vaccine market. I'm very confident that they will receive approval either in June or July. And I'm going to talk about Novavax on the next slide, but I want everyone to remember that there is a long process with multiple different checkpoints before vaccines can be either authorized or fully approved. And there's a 5-step process in the US. An independent third-party FDA advisory panel meets and makes a recommendation to the FDA commissioner. That's what's happening today and tomorrow about the child and adolescent vaccines. Then the FDA commissioner gets advice from FDA staff and makes a decision. That triggers another independent review by the Centers for Disease Control. And the advisory panel, again, is an independent third-party panel. They make a recommendation to the CDC director, who then makes a recommendation either to authorize or approve. And then that goes to each state Department of Health Services to decide what happens at the state level. These things now happen very quickly, but again, I wanted to remind everybody, there's no single person or organization that makes the final call on whether we authorize or approve these vaccines. Next slide, I want to talk a little bit about Novavax. I actually have been talking about this since very early in the pandemic. The technology that Novavax uses is called the protein cassette method. And it's actually a very old technique. It's generation 2. The first generation of vaccines would be to either kill or attenuate the actual virus and use that as the vaccine. The second generation vaccines used protein components from the virus, either that were purified from the virus or artificially synthesized. And so Novavax uses a manufacturing technique to artificially synthesize a piece of the spike protein. That's mixed with an adjuvant or a stimulant that separately stimulates the immune system so that you get a stronger immune response. This is very old and well-established technology. It's used for the shingles vaccine, some of the cervical cancer vaccines targeted at papillomavirus, and various DTaP vaccines that we all are very familiar with. So there shouldn't be a lot of resistance based on this being a new technology. So this will be the first what we would call classical option to be offered in the US. And this might be preferred by some people that have been hesitant or reluctant or can't tolerate either the vector vaccine from J&J or the mRNA Pfizer and Moderna options. So I think this is promising news. Next slide, please. So before I go into monkeypox, I do want to send one cautionary note about the continuing evolution of COVID-19. The BA4 and BA5 variants have taken hold in the US. They're circulating widely in Europe and in South Africa, and they are still Omicron subvariants, but they also have some elements that we saw in Delta that are thought to confer a competitive advantage, not just in terms of increased contagiousness, but increased pathogenicity. So these two variants in laboratory studies have been shown to be more likely to infect lung cells and to replicate or duplicate at 2 to 4 times the rate as the BA2 and the BA2 12.1 variants that are circulating right now. So again, with COVID, we always have to monitor what's happening in our community. We should hope that there continues to be a favorable decoupling between cases and severe outcomes, but that's something that remains to be seen. And by the middle of July, BA4 and 5 will be the predominant circulating variants in the US. So I want to switch to monkeypox. I've been receiving a lot of questions about monkeypox. Just some background. It's a member of the orthopox virus family that also contains smallpox, cowpox, camelpox, and horsepox. It's not from the same family of viruses as chickenpox, even though they cause similar lesions. And we've known about this virus for a while. It was first discovered in 1958, and it's endemic in some West African and Central African countries. There have been periodic outbreaks outside of West and Central Africa, but typically those are very limited and have not caused an endemic spread within other countries outside of Africa. There have actually been outbreaks here reported in the US. There were 2 cases that were confirmed last year. And we had a very famous outbreak here in Wisconsin in 2003 that was associated with exotic pet prairie dogs. So we have had monkeypox in the US in the past, but again, it is not endemic here. Typically, this is a disease associated with travel to endemic areas. It's also not from the same family of viruses as coronavirus. It behaves very differently. The COVID-19 virus is an RNA virus, and the monkeypox is a double-stranded DNA virus. So they're not from the same family. Next slide, please. So monkeypox typically resides in what we would call animal reservoirs. In other words, it circulates amongst animals, and then when they come into contact with humans, there's a cross-species or zoonotic transmission to humans. And in Africa, the 2 primary reservoirs that also serve as transmission vectors to humans are macaque monkeys and Gambian pouch rats and other rodents. We also know that this animal to human spread is the most common route through which people become infected, but it can be transmitted from human to human, primarily through prolonged close contact or exposure to contaminated clothing or bedding. It is possible, but less frequent, to have transmission by large respiratory droplets. So if someone is in close proximity to you for a long time, if you're kissing them, if they're coughing within a short distance of you, it is theoretically possible that you could acquire monkeypox through the respiratory transmission route. Unlike COVID-19, though, there is no evidence that monkeypox can be transmitted through persistent small aerosols. So you're really going to need to have close contact to have a clear risk of transmission. If I could go to the next slide, please. Monkeypox is potentially a lethal disease. It can kill as many as 1 in 10 people who contract it, at least in Africa. And there are 2 predominant variants of monkeypox in Africa, and I haven't really seen a lot of lay press about this. So the West African clade has a mortality rate of 1 to 4%, and the more pathogenic clade, which is called the Congo Basin clade, has a mortality rate of up to 10% in the African experience. Now, the 2 variants that are circulating in non-endemic countries, and so far those have been reported in Europe, North America, and Australia, are derived from the less pathogenic West African clade, which is fortunate. Also, thus far, the monkeypox cases reported outside of Africa seem to cause less severe disease than we typically see with that West African clade when it's transmitted in Africa. So next slide, please. So there are widely dispersed cases in Europe and North America and in Australia. About 1,400 cases confirmed in over 30 countries now. About 50 cases have been confirmed in the US in more than a dozen US states, and those counts and the number of states involved seem to be rising every day. The largest number of confirmed cases in the US have been reported in California, Illinois, New York, and Florida. And so in Illinois, it's very likely that there will be or already are some cases here in Wisconsin. And at least 75% of the US cases so far have been associated with international travel. So people who have traveled to endemic areas or to areas in Europe that are seeing community transmission of monkeypox. Most of the rest have been secondary contacts, in other words, people coming into close proximity with those travelers. But there's still a smaller number with no known contact, and we're seeing that in Europe as well. So that means there's probably silent community transmission going on. And this may be that the cases are milder, that people aren't, clinicians aren't really aware that of monkeypox being a potential cause of some rashes that people see, and the non-specific symptoms associated with monkeypox. So the initial cases in Europe were associated with raves and sauna parties, predominantly amongst homosexual men, but not strictly limited. And this is not necessarily a sexually transmitted disease or a disease that will predominantly affect gay people. So I want everyone to understand that if there's a risk, it's for all of us that may come into close contact with other people. Next slide, please. Again, though, the risk right now is low. So monkeypox is usually a self-limiting disease, but as you see that the mortality rate could be up to 10%, it might be severe in some individuals. Unlike COVID-19, when you can transmit the disease when you're not feeling symptoms, that's not the case with monkeypox. You really need to have an active lesion or a rash to be able to transmit to another person. So it is not contagious during the incubation phase. So that means if you're in a grocery store, you're having an incidental transient contact with somebody else, you're very unlikely to get monkeypox, even if the other individual has monkeypox. The symptoms emerge 5 to 21 days after exposure, typically 1 to 2 weeks after you've been exposed. And these monkeypox symptoms are similar to those of smallpox, usually less severe. And quite honestly, these constitutional symptoms are not very specific for monkeypox. So fever, headaches, muscle aches, chills and rigors, exhaustion and fatigue, all symptoms associated with many viral diseases, including the flu. Two things that are different: you do have a rash, and unlike chickenpox, you can have very severely swollen lymph nodes, which typically is not a manifestation of chickenpox. And as I said, most of the cases have been mild so far. The symptoms are nonspecific, and the rash changes, and it starts as a subtle red rash, typically on the face, although because of the nature of the current spread being associated with close, intimate contact, not necessarily starting on the face, perhaps in the genital area. Next slide, please. So here are some pictures. The skin lesions begin with a reddish rash. You don't see a picture of that here. It starts in the face and then typically extends peripherally to the trunk, the arms and legs, and then eventually to the hands and feet. Now, if you look on the right, you can see a typical monkeypox case that typically has up to 200 lesions. We're not really seeing that in the current outbreak. So typically people have 5 to 10 visible lesions. So these lesions start out as papules, which are simply raised bumps with no fluid. They then turn into what people call a blister or a vesicle that are filled with clear fluid. Then they turn into pustules in which the fluid becomes milky in composition. And I think you can see that on the thumb in the upper left there. Eventually, they develop umbilications or a little crater in the middle, and then they begin to collapse. And you can see that in the picture on the lower left. There's an umbilication that is beginning to collapse. Eventually, as you can see on the hand picture, the third from the left on the top, they develop ulcers that begin to scab over. When the scabs fall off, there is healing and typically some scarring. So especially if you have severe lesions on the face, they can be disfiguring. Once the scabs fall off of every lesion, you are no longer contagious. And that typically takes anywhere from 2 to 3 weeks for the disease to run its course. And again, most people have spontaneous resolution without any severe prolonged side effects. Next slide, please. Now, there are no specific treatments for monkeypox. Some dermatologists recommend antiviral creams, such as 3 to 5% cidofovir, which is available in generic formulations, so it should be inexpensive to use. The best preventive treatment is post or pre-exposure vaccination. Fortunately, we have very large stockpiles of vaccines that are either approved for smallpox, and that would be the Jynneos vaccine, or are likely to provide some protection from smallpox, but they're really authorized, I'm sorry, for monkeypox, sorry, but they're authorized for smallpox. So the ACAM 2000 is a live vaccinia virus that you inoculate into the skin once. And this was used quite a long time ago for smallpox. The problem with this is, first of all, it's not approved for monkeypox, although it's very likely to give you a good immune response. We have 100 million doses of this in the US, but the individuals are considered to be vaccinated 28 days after inoculation. But in theory, you can spread the vaccinia to other people while you have an open wound. And in fact, if you scratch it, you can spread it to other parts of your own body. So people need to cover the lesions and take precautions to avoid spreading. So that makes it an impractical vaccine. The Jynneos vaccine is really interesting. It's a modified vaccinia Ankara strain. They call it an MVA. It is a non-replicating virus. So you give that by subcutaneous injection twice, 4 weeks apart, and you're considered to be fully vaccinated 2 weeks after the second dose. Because it is a non-replicating virus, there is no risk of spreading the infection to anyone else or by scratching it, carrying it significantly anywhere else on your own body. We don't have a lot of that available in the US. We have 72,000 doses available. The US government has ordered another 300,000 doses that are supposed to be delivered by the end of June, and then 500,000 doses to be available during the summer. And so your providers are learning about how to recognize monkeypox. Public health departments are planning to be able to distribute the Jynneos vaccine if it's necessary, if there is a significant amount of community spread, or you have a documented exposure. Again, post-exposure, you can still take this, and it can provide some protection for you. So we're going to learn a lot more about monkeypox. We're not raising the alarm bells right now. It is very unlikely that this is going to become a COVID-level pandemic in the US or in the world, but there are some concerns, and I want to talk about those on the next slide. So the CDC raised the travel warning from level 1 to level 2, and there was some confusion because they had talked about wearing masks. Really what they're saying is when you travel outside the US, avoid close contact with sick people, which is common sense, wild animals or exotic pets, and any potentially contaminated materials, again, which is common sense. As I mentioned, monkeypox is unlikely to cause a pandemic here because it's not contagious during incubation and it requires prolonged close, intimate contact. But there is concern about the silent community transmission that we're seeing in multiple communities. The mild nature of the disease may make it transmissible before people know that they have it. And the real concern is that we may have enough of a burden of monkeypox in the US that it could become endemic here and perhaps other currently non-endemic countries. And the real concern is that it could establish animal reservoirs in the US, like the rats and the macaque monkeys in Africa. And that is a concern because once established in those populations, it's very hard to extinguish. You can't use public health measures to eliminate that. And there also is some concern that the reservoirs could be our pets, which could be a very significant problem for us. And if I could go to the next slide, just showing here graphically, on the left, you see some of the established monkeypox vectors or reservoirs. A vector is simply a vehicle for transmitting the virus from one entity to another. A reservoir is a place where the virus can thrive and then eventually emerge and threaten humans. So you've got the Gambian pouch rat, prairie dogs, and the macaque monkeys that are either vectors or reservoirs well established. But what would happen in the US if monkeypox infected cats and dogs, or cows, or pigs, or sheep, or other domestic animals? And so that is something that I think we need to have a heightened awareness about, and that our epidemiologists and public health experts need to be focusing on in the short term. And with that, I will turn it back over to Chris.
Well, thank you, Dr. Raymond. Enlightening as always. We have some questions from the audience here that I'll run through now. So are you taking into, a question from the audience, are you taking into consideration the wastewater surveillance numbers from the Wisconsin DHS in your summaries?
I am. Yes. Yeah, it's really a great question. In many ways, the wastewater levels, if done properly, are better indicators than either the positivity rate or the cases, because so many people simply aren't going in to get formal PCR testing now. Those have been pretty steady. They've fluctuated up and down a bit, but the levels of wastewater contamination are not approaching what we were seeing back in January with the first Omicron strain, and they're not really going up. So we're probably at a steady state.
Yeah, at the risk of exposing myself as a nerd, I actually do check the wastewater levels probably once a week.
Chris, that's not the only evidence that you're a nerd, but it's okay.
That's a fair point. Another question, should people who have had the mRNA vaccines and boosters consider changing to the Novavax, or are they not compatible?
I would say eventually that may be a consideration, but the way approvals work, I don't think that the CDC and FDA, even if they approve, and I expect them to approve Novavax, are going to suggest, at least early on, that there should be cross-vaccination with this platform. We know that there is a growing disparity right now between people that have received 2 shots of the mRNA vaccines, in other words, formerly called fully vaccinated, and whether you have 1 or 2 boosters. So we know that 1 mRNA booster gives very significant protection against hospitalization and severe disease, and that that protection is clearly better now at this point in the pandemic than simply having had 2 shots of an mRNA vaccine. So I think the CDC recommendation to get boosted is a good one. And not many people, unfortunately, are following that advice. We've kind of been stuck a little below 70% for people in the US who've completed the 2-dose regimen, and 35% or so that have been received 1 booster. And again, most clinicians would say, get your booster and don't worry about what's going to happen in the fall. Getting a booster now will not preclude you from getting whatever formulations are available and recommended in the fall.
That's a good point. So given the symptoms of COVID-19, the decoupling that you talked about between bad outcomes and spread, do you anticipate the CDC changing their current isolating or quarantine recommendations?
Well, at some point, they're going to change them as the pandemic evolves. But I actually don't think that's going to happen in the next few months. They're still recommending 5 days of either isolation or quarantining, depending on whether you test positive. And anything shorter than that, you probably would be risking exposing other people to the virus. And in fact, there are clear cases of people that have no symptoms, but have persistent viable virus that they could pass on to other people after that 5 days. So, and also, as I mentioned earlier, we're watching very closely to see what the biological and epidemiological characteristics of BA4 and 5 are going to be. Those will be the predominant strains here in July, and we just don't know that much about them yet.
All right, a couple more minutes, a couple more questions. Is there any guidance right now on any populations who should get the monkeypox vaccine without a known exposure?
Anyone working with exotic animals might want to talk to their doctor. So importers of macaque monkeys, rats, prairie dogs, at least now might be. Folks that by nature of their occupation might be exposed to others. But there is not a recommendation right now for any specific populations to be vaccinated.
Well, there goes my side hustle. One last question before we let you go, Dr. Raymond, and thanks again for being here. If a person is from the generation that received the smallpox vaccine as a child, should they get either of the other two vaccines for monkeypox?
Yeah, I actually don't know the answer to that question. It's a really good one. And I'm not sure that people have really studied lifelong immunity from smallpox. So that's an outstanding question, and I actually don't know the answer to it.
Absolutely. Well, thank you for your time, Dr. Raymond. We really appreciate it as always. Programming note for everybody here. We're likely to skip the July edition of the webinar just because we're around 4th of July right now, but we thank you for attending as always. You can find a copy of today's presentation from Dr. Raymond on MMAC's website and a replay of today's program on our YouTube channel a little bit later this afternoon. Thanks again, everybody, and have a great day.